Welcome to another episode of the Nuclear Medicine, Molecular Medicine podcast, and we're here in Vancouver at the Society of Nuclear Medicine meeting. And like we try to do every year, we have what I consider the highlight of the meeting, and that's the image of the year recipient winner, and that's Johanna Dinkman, and she's going to tell us a little bit about her wonderful, unique, special image. And so before we get to that, I'll just if you could tell us a little bit about yourself.
Yeah, sure. So, hi.
Hi.
I'm Johanna. I'm from Hannover Medical School. I work with Frank Bengel. He's my boss. And I'm currently in my 5th year in nuclear medicine, and I'm finishing my specialization on nuclear medicine this year. That's how we do it in Germany. And
Right.
then I'm a fully qualified nuclear medicine physician afterwards. Yeah.
Right, and you did this on cardiology. I know I've known Bengal's work for neurology previously, but you've done this is a cardiac image now.
Yes.
Tell me a bit about this cardiac image. What did it show, and how's it done?
Yeah, well, we all know the new FAPI traces, right? You already did
We've already done a
some
podcast
content
on
about
FAPI
that,
Australia.
right?
It's been
So-
image of the year, and,
Yes.
and
so,
it's also used for. It's now starting to be used for theranostics
Yep.
and so on.
So, of course, it's primarily designed for oncologic imaging, but as we know, fibroblasts or activated fibroblasts are in so many processes in the whole body, and they have so much to do throughout the body, and also in cardiac disease. And
Yes.
this is a huge research topic in general at the moment, also regarding development of new therapies. We see a huge dynamic on the cardiovascular research field in fibrosis.
Right. So when you get fibrosis in the cardiac tissue, often as a result of an insult like a ischemia and so on.
Yeah, that's true.
That reduces the ability of the heart to contract properly, and it
Right.
it also forms an odd shape to the heart, which makes it hemodynamically not suitable. Would that be correct?
Yeah. So for example, after injury, which can be ischemic injury due to myocardial infarction, there are fibrotic cells activated in order to build a scar. But sometimes we see something that's called excessive fibrosis, or also interstitial fibrosis, where the fibroblasts maybe do too much, and where they not only repair the scar but also lead to kind of a stiffening or less contractility of the left ventricle,
Right.
and then it can lead to a worse functional cardiac outcome and ultimately lead to heart failure.
Right, and so cardiac fibrosis is one of the more common forms of causes of heart failure,
Yes.
and heart failure is almost replacing ischemic heart disease as a leading cause of cardiac death, isn't it?
Yeah, that's true. I think the acute treatment of heart attacks is so good nowadays.
Yes.
There is a high standardization, and it's working very well.
Yes.
With the revascularization therapy and everything. But maybe the early cellular processes after the infarct are undertreated.
Right.
What's happening on the molecular or cellular level? There could be some point where we could intervene with new technologies or therapies to more improve the outcome of heart attack patients.
Right, so there are therapies that can reduce this fibrosis?
Yes, there are some emerging therapies.
Right.
We have a collaboration with the colleagues from the University of Pennsylvania,
Yes.
and they recently published in Science a great work on CAR T cells
Oh yes, absolutely.
that target fibroblasts. So
CAR T cells we use in oncology, right?
Right. So there is also something going on there, and there are also other immunotherapies against maybe fibrosis. It's emerging, so it's not ready yet, I think. But what we would find great as application for PET scans is maybe to identify patients who would be suitable for such kind of antifibrotic therapies.
And of course, CAR T therapy is notoriously expensive, right?
Yeah, I think so.
Right, so you want to be selecting people very carefully for it.
We should do that.
Right, so that makes it a perfectly good thing. Okay, so we've got an imaging agent that can pick up fibrosis. But your image didn't just show that imaging agent. What else did it show?
We looked specifically at the heart. We had patients with acute myocardial infarction who underwent revascularization therapy, and we did several imaging things. So we, on the one hand, took myocardial perfusion imaging.
Right, and how was that done?
That was done about 5 to 7 days after the infarction. The patients were still in the hospital and underwent a rest myocardial perfusion scintigraphy, like standard.
Right, so
repair,
SPECT
right?
scintigraphy. Right?
Yeah, SPECT scintigraphy in order to obtain the infarct area size, to know where there's still a hypovascularization or hypoperfusion, and then in a we tried to do that on the next day, so that there's not a huge time difference between the imaging modalities. They underwent a PET scan
Yes.
with gallium FAPI 46,
Yes.
which we kindly got the precursor from Heidelberg,
Yes.
from Uwe Haberkorn, and that was also easily done. You inject it intravenously, you wait 1 hour, and then do the image. And that's kind of imaging with FDG from the clinical part.
So what would you like to see in this patient? What would you like to see in terms of matching up the perfusion abnormality to the fibroblast FAPI image?
The first ones we were not sure what we would see. We speculated that we would definitely see a high uptake in the infarct region.
Yes.
We'd
like to see
sure.
that because that's normal repair, right?
That's right. So that should be the case. It was the case. And what was new is that we also saw a huge area around the injured area, and that's something we did not know so far. So there is also a fibroblast activation in the surrounding tissue. We don't know yet. Maybe it's the area at risk,
right?
Something like that. We don't know that yet. We have to figure it out.
You want to do a sample of people to see who goes on to have cardiac failure, who goes on to have. But there's other things you probably could do. I mean, you could do ultrasound to look at motion more.
Yes.
Do those sorts of things as well.
We also did that in part of the patients. That's
okay.
True.
Yes.
So the one interesting thing when we're talking about wall motion, we also looked at the wall thickness.
Yes.
From the MRI. We also did, and there we found differences in the contractility of the different FAP positive or FAP negative areas. So there seems to be a local effect of the FAP positive areas in the myocardium on the contractility and the function.
Right.
Mm-hmm.
So you've got a a functional aspect, and you can match them up. And if you see an area that's much bigger than the perfusion defect, then you're going to say, this person might need some CAR T therapy. If it's smaller than or the same size as the perfusion defect, then probably that's just normal. And although maybe you want to do this 6 months later or 12 months later to see whether we've still got fibroblasts working away doing damage. Is that something you've got in the plan?
What we are doing is that we look at follow-up MRIs at the moment. So functional follow-up after about 6 months. We already have some preliminary data on the LVEF from echo or MRI, and we found a significant inverse correlation of the FAP volume in the myocardium and the later ejection fraction. And more fibrosis, worse function.
Right. Yeah. Did you do any FAPI scans delayed to look at? No.
Not at the moment, but we maybe plan that. Not at the moment. It's not ready yet.
Right. Yeah, but I guess you'd want to see whether it's an ongoing chronic problem.
Yes. I mean, it would be highly interesting to have later FAPI scans also to follow up these local changes with FAPI also. At the moment, we are doing it with the MRI because of radiation and so on.
Right.
Always. Then we would need to do another official study.
Right, then you have to get it through exhibits radiation.
Maybe you will do that as next step.
Yeah. Excellent. Well, that's a really cool, different approach. I mean, it's great to see something used in oncology be taken over the cardiac and not only Well, it's not only oncology in terms of FAPI, but it's also oncology in terms of therapy.
Yes,
so,
right. There are some similarities there, maybe.
Yeah.
Mhm.
And that's the beauty of functional imaging, right?
Yes, that's what I like about it.
Yeah.
So we are finding new targets and use the imaging to select patients for proper therapy. I think that's great.
Have you thought about using it in musculoskeletal disease, for example, or plastic surgery, or all those sorts of
I
things?
think there's a lot of possible application. I think some German colleagues are looking at also atherosclerosis and so on. So
Pulmonary fibrosis?
It's you can do everything. I think
Probably hypertension?
everything. Yeah.
All of those kinds of things you could possibly use it for.
Yeah, probably. We have to figure that out.
Yeah, because there's lots of disease processes that involve fibrosis.
Absolutely. Yeah, it's of high interest. Yeah, I mean, in the images, it is always more, I think, a very specific uptake, which is good in general if you want to do therapies, and it's always a high uptake based on the SUV, right? So these might be good conditions in order to have also a specific therapy there and not harm too much any other processes or physiological processes.
Right. You did say used in other vascular, perhaps aortic aneurysms or other sorts of things?
Yeah, maybe. I have not done that yet.
Right. But I'm thinking, any place where you want to see that there's something in terms of removing the elasticity that leads to an adverse outcome.
Yeah. What we are also doing is we are currently looking at patients who have aortic stenosis and due to that have heart failure.
Right, and they have stiffening of the heart walls and they have thickening of the myocardial as well.
Yeah. Right. We also looked at some patients, that's only 18 at the moment, but we figured out there are huge differences in the amount of detected fibrosis in the heart in these patients. And for them it could also be interesting to have maybe, let's say, an earlier option in the duration of the disease to get earlier treatment, because then these people are often asymptomatic for a very long time.
Yes.
And then the only thing you can do is to replace the valve.
Yes.
And
then if you replace it too late, then you've already got that permanent loss of function.
The remodeling can be irreversible at a certain time point, also regarding fibrotic processes and so on. So it would be great to know earlier what's going on.
And perhaps even in more pediatric applications like rheumatic fever and so on. That would also quite nicely fit in that situation, wouldn't it?
That's true.
Mm-hmm. Yeah, so there's a lot of different things you could.
Yes.
You've just, well, I don't know. What's a cornucopia of things that come out, in terms of it started by just thinking a little bit outside the box.
Yeah.
Actually, it's crazy that people haven't been doing this earlier. We didn't have to think about it.
I think we had the idea right in the beginning. I mean, we are primarily cardiovascular researchers in Hannover with Frank Bengel and also Jeff Zachary, who used to the preclinical stuff, and me now also. And when the new FAPI tracers came, we were immediately thinking about cardiac applications. And first patients were already scanned to 220 or something like that. So.
Yeah. Excellent. Well, thank you very much for taking part in the podcast. Anything else you'd like to say or relating to this?
NuclearMedicine is a great job.
I totally agree.
Lots of fun, and you can do cool stuff.
So where could we find out more about this? Have you published?
It's published in JNM.
Yes.
And we also had a earlier selection case report or extended case report in JACC Cardiovascular Imaging, I think in 2021.
Yep.
You can also find the work there.
Excellent. All right. Thank you very much. And
thank
you
you
for taking part. And congratulations.
Thank you so much. Okay.